Okay, so the first family of CYP enzymes we're going to talk about are the CYP3A subfamily. And so this family is important. I said it metabolizes over half, more likely two-thirds of the drugs that are in current clinical use. And it's actually the most abundantly expressed CYP P450 enzyme in the liver. And so in terms of substrates, so these, again, for review, these are drugs that are biotransformed by CYP3A4. Okay, so codeine, acetaminophen, cyclosporine, diazepam, erythromycin, all the statins, warfarin, and Taxol. Okay, so all of these drugs and others, a lot others, get biotransformed by CYP3A. Okay. Now the inducers include, so these are drugs that induce CYP3A4. Okay, not so much are biotransformed by it. So barbiturates, carbamazepine, glucocorticoids, rifampin, the herb St. John's wort, and phenytoin. Okay, these are all well-known inducers. Okay, and then the inhibitors are clarithromycin, fluconazole, grapefruit juice, ketoconazole, and ritonavir. All right, and so you don't need to know these specifically for for this particular exam, but you will need to know them clinically while you're practicing. Okay, and most people don't remember all of these off the top of their head, which is fine. I certainly don't. But whenever you write 2 or more prescriptions and Epic or the pharmacy calls and says that there's a drug interaction, um, this is the basis where that drug interaction is coming from. Okay, so it's a good idea to not necessarily memorize these blindly, but to understand that these are kind of like the red flags. Okay, how about CYP2D6? So this is the more this is the other cytochrome P450 enzyme that's responsible for biotransforming about a quarter of the drugs out there. So again, the substrates, I'm not going to read them all, but the substrates for CYP2D6 are listed there. At this point, it's not really well known if there's any bona fide CYP2D6 inducers. Okay, so we don't really see many drugs that have the capability of inducing this enzyme. But we do see a really important genetic component to this. And so we've identified some patients that just are slow metabolizers of this drug. We've also identified other patients who are fast metabolizers. Okay, but that doesn't mean that the activity of this enzyme was turned on or turned off because of another co-administered drug. Okay, this was because we've actually identified patients who have polymorphisms, and so this will be discussed in the next couple of slides. In terms of inhibitors of CYP2D6, there's not that many. Quinidine and paroxetine is an antidepressant, are really kind of the only 2 well-known drugs that are usually referenced in the literature. I'm sure there's probably 1 or 2 more inhibitors. But again, I'm not going to ask you specifically that. The main concept here is that when we talk about CYP enzyme induction, we're referring to CYP3A, okay? Specifically CYP3A4, I should put a 4 in there, really. This is all generalities about the CYP3A family, but what we're talking about in terms of the drugs is really the CYP3A4 specific member. So CYP3A4 can be induced quite dramatically. CYP2D6 usually is not induced, but has the genetic polymorphisms. They both have their own individual substrates, and they both have their own individual inhibitors. Okay, and so this is what these polymorphisms look like. And so this was pretty common with the majority of these drugs. We've identified patients who had really good responses. We've identified patients who've had really bad responses. But the bulk of the patients are in the middle. Okay, so they have this kind of average response that we would expect with a given drug. All right, and it came down to how quickly they metabolized the administered substrate. Okay, so the patients that had really, really poor responses were poor metabolizers. And the drugs that had really, the patients that had really great responses were deemed ultra-rapid metabolizers. Okay, and most of the patients were somewhere in the middle. All right, so let's look at an example. So here's tamoxifen. Okay, and this is indicated for estrogen receptor positive breast cancer. Okay, and tamoxifen, when administered to these patients, gets biotransformed by CYP2D6, and the patients experience a reduction in tumor size and incidence by the active ingredient endoxifen. Okay, so tamoxifen gets converted by CYP2D6 into endoxifen. Okay, and we said from a genetic standpoint, this CYP2D6 enzyme is not really inducible. All right. Now, what we've noticed is that when you look at the whole patient population, you can identify various cohorts. Okay, so we've, in the literature, there's a group of patients with a ethnic or racial difference that have ultra rapid metabolism of tamoxifen. Okay, and these patients here in purple had phenomenal responses. Okay, and that's due to the fact that their CYP2D6 was essentially super active. Okay, so they had phenomenal responses to tamoxifen. The breast tumors shrunk. However, in this cohort, we've identified patients that have, some of these patients reported an increased incidence of side effects and toxicities. And the reason is because of the metabolic cascade. They achieve the plasma concentration faster than these patients. Okay, so, for example, say 10 milligrams of tamoxifen is administered for these patients, and we see this effect. Okay, these patients also received 10 milligrams. Okay, but not only did they have an increased response, but they had increased side effects. All right, so what does that mean? These patients would probably be better off getting maybe 7 milligrams. Okay, just because they experienced more side effects and toxicities, and their response rate was even better. Okay, so if this offered say this offered a 70% reduction in breast tumor tissue, this would offer a 90% reduction, which is phenomenal from a cancer perspective, but also you have to worry about the side effects and toxicities as well. Okay, so that's one group of patients here in purple. Okay, how about the patients in brown? So those same brown patients had 10 milligrams of tamoxifen, okay, and they had practically no response, okay, in spite of the fact that their tumor was estrogen receptor positive. Okay, so the molecular target's there. You're administering a drug which binds to the specific receptor, okay, and they had practically no response, okay, and that's because they were poor metabolizers. All right, so 10 milligrams of tamoxifen was administered to these patients, okay, but they didn't have a response. So what actually happened was 10 milligrams was administered, but only 2 milligrams was biologically activated because their metabolism through the CYP2D6 enzyme was so poor. All right, here's another example where maybe you've got comorbid conditions, and this may or may not be completely clinically relevant, but I wanted to show you an example of which. So here's a patient in red that has underlying OCD or depression, and they're treated with the SSRI paroxetine. Okay. What we've noticed in these patients is that the chemo doesn't work, and that's because paroxetine also is biotransformed by CYP2D6. And so if this particular patient population was average to below average in their CYP2D6 activity, there's only so many CYP2D6 enzymes. If you're co-administering this drug plus this drug, there's not much room for biological activity. And so, one way of looking at it from a chemistry perspective is that the affinity for CYP2D6 might be higher with paroxetine, so more paroxetine is getting biotransformed and less tamoxifen. That's one way of looking at it. So I think that clinically this makes sense. You've only got so many enzyme systems. The more CYP2D6 substrates you start piling on, the harder it is for this enzyme system to keep up. And so these patients, even though they may be physically able to biotransform tamoxifen, they weren't, probably because this relationship had a much stronger affinity. Okay, and so this isn't, we're not looking at inducing CYP2D6. We're just talking about, you know, spreading spreading your resources too thin. Okay. So let's take a break here. I want to go through some of the metabolic pathways of tamoxifen, just to kind of bring this whole thing together.